thank you for inviting me along to talk about this. It looks it could be a bit dry. I'll try and make sure it's not dry. The main things I want to draw out from it are issues about what was discussed, and actually Joy could have done this session because she was on it as well, but she's not admitting to that, so I've just outed her for being on the nice guideline group, haven't I? But Joy might have a different take on it, so if you've got other views on it, Joy, please do. So it'll be my interpretation. I'll say what happened in there. No, I won't, we're not allowed to do that. I'll say what we produced from it and why it might be important in relation to the wider set of areas, because it's about the mental health area. But I don't think it just applies just to mental health. It's in terms of the ideas and the recommendations for practice and policy, which I think are valuable. Okay, a little bit about my background. I'm a social worker, and think about what Paul was saying this morning about who helped you figure out what you do about dealing positively with aggressive or violent behaviour, or indeed at all, knowing anything about aggressive and violent behaviour. I started working in social work in an organisation called Cyrenians. Do anyone remember Cyrenians? Thank you. At least someone does. It's when you talk about it and no one remembers it. But it was great because we went to work with single homeless people and you had a 36-hour week. That was the time you had off. Actually, you lived in the unit and you had the same amount to spend every week as your residents did. So just to give you an idea about how old I am, how much was left over for people to spend on their own things when I was working at Cyrenians in London, please? I guess?
10 bob.
50p.
10 bob. Even I can't remember that far back.
You carry your age so well.
What that is. I'm trying to work out what that is. £1.85.
Yeah.
Okay? That was what we had to live with. Clothes, the lot. Okay? But when I went to work there, people came from everywhere, okay? Homeless people. There was lots of aggression and violence. We were young kids. None of us knew what we were doing. It was actually quite dangerous. Okay, so we move on. I worked as a nursing assistant in various psychiatric hospitals around London and Hertfordshire. And then eventually I worked as a social worker in Claybury Hospital. This is the other. Anyone remember Claybury Hospital? In Essex?
Yeah,
wow,
I'm an Essex boy.
Fantastic, right, okay. It's all luxury apartments now, isn't it?
Oh, absolutely.
Yes, it really is. The bee's knees for somewhere to live. So I was there for a while. No one ever told me about anything to do with aggression. I went on a 4-year social work training course. I think we're getting the message now, aren't we? What did they talk to me about dealing with aggression and violence on my social work course for 4 years?
Nothing.
Thank you. Not a sausage. No one ever told me that someone might not want to see me. Okay? And might actually be, have views about me as a social worker, or me, or whatever it might be. When I went to work in London, okay, the social service office, there's quite a lot of aggression and violence. Who told me or inducted me to do anything about it? No one. Okay? So from that, I got an interest in doing it. I brought it up in a meeting once and said, look, there's a bit of a problem here. This is happening. Nothing's happening. You might get a cup of tea if you were lucky. But actually nothing happened for the service user either, in terms of support or in terms of trying to deal with it. So the boss said, okay, Brian, why don't you set up a training course? Which wasn't the idea really, but okay, so we got something going from that. So I've been involved in a number of years of training. In my sort of academic career, it's been a big area for me in terms of research. I've done research around sort of mental health areas and risk assessment, in terms of safeguarding children and issues there, and in terms of restorative justice. We introduced restorative justice into residential units in Hertfordshire. And the feedback from everybody and the quantitative elements of that showed it worked. And it's with the sorts of things we're talking about today. It's not about blame, it's not about punishment, it's about dealing with it appropriately and positively. We all have times when we've got difficulties and do things. Punishment's not the way of doing it. And that was the feedback from the young people and the staff and the police in that area. So it's just in terms of background and how we're thinking about these things. So therefore my spin this afternoon is to pick out from what we were doing on that nice guideline development group was about collaborative approaches and trying to be more positive about how we view it and deal with it. And I think the other bit about what works from what's in the conference title is from whose perspective. Because sometimes we kind of think, does it work from the service user's perspective, or does it work from the staff's perspective? Because it can be seen differently, I think, at times, in certain ways. And I don't think it is at all. I think the interests and rights of each are as important as the other. And if we don't deal with them properly, we are missing something, and it's not providing a good environment or a good way of us all learning. The other thing I want to talk about is learning. Are we a learning organisation where we are, to take into account the perspectives from different people? Because we need to do that, otherwise we can't understand it, and actually we can't do anything about it which works. Because it won't work. Because it won't work for some people, because their views haven't been heard. Do people know about NICE? A lot of people do. Just very quickly, it's an organisation which produces guidelines and does other things in relation to, particularly the health service, of course. In terms of, if you get inspected in the health service, they might bring up some of the NICE guidelines and stuff. And if something goes wrong, they might come and look to see if you've been following the guideline, okay? What's changed in the last couple of years is that social care has come into that as well. I don't think social care has quite understood this yet. And we'll see when there are inspections, when they say, what about the NICE guidelines? I say, what are you talking about? Be interested to see what the dynamics of that is. But people do seem to take notice of them. So it is something which we need to think about and unpack to see, are these things valuable or not? And what are they talking about? And is that valuable or not in terms of what we actually do? Okay, so that's the title. If people want these slides, there's loads of them. I do too many. I'll whip through quite a lot of them. If people want them, email me. I'll send them to you, okay? It's like a handout as well. I think I'd take two key features from the 2015 guideline about reducing restrictive interventions in inpatient and community mental health settings. It's both areas. I think we're still struggling to get the issues about community mental health in there. That's one of my areas of interest. A lot of the stuff, of course, we talk about is in the best form of the word, institutions, in health and in education, okay? There's a lot to be done still to understand and do stuff out in the community where people are working in slightly different ways. And it's all this new about this important area about reducing restrictive interventions. There's a quote. You've got to guess when it was said. The entire absence of restraint, this is someone who's looking at a unit, okay, for people with mental health issues. The entire absence of restraint with the general prevalence of order and quiet is very striking. Anyone like to guess when that was said?
1865.
Sorry?
1807.
That's a pretty good guess. There's another guess.
Somebody said 65.
1965 or
1865.
1865. That's not bad actually. If we take an average, it's 1839. And it was Samuel Tuke who ran the York Retreat, okay? He was visiting the Northampton Asylum in 1839. It's an issue that came up earlier today, that's interesting. Maybe it was and maybe it was wonderful, and they obviously weren't using restraint, or depending how we define it, was it Linda who was talking about that, about how we define what restraint is? Maybe they just didn't see it. But hopefully that was the case. I think the point is, the idea that restraint, we should try to avoid it wherever humanly possible, has got to be a good thing. So, how are we thinking about that in terms of things like staff culture and training that relate to de-escalation and use of restraint? And also, for me, an important was the recommendation about the inclusion of service users in policy development and in terms of what happens if an incident happens and afterwards. Okay, so I think it's about human rights and respect. We've heard a lot about that today. About advanced decisions and advanced directives, that's referred to in the guideline actually, as a way of doing it. What do we unpack? If something's happened, how do we talk in a way with everybody to try and make sure things are learnt from it, not only for the individuals involved, and I mean that for the staff as well as for the service user, but for the organisation and agency as well. What can we learn as part of a learning organisation, hopefully part of a no-blame culture? That's what we do in the airline industry, by the way. That's how they learn, and they have very few accidents. People report stuff, they talk about it. Okay? Key feature in terms of risk assessment there. So how do we get to those decisions and directives that help improve the situation, not only for the individual, but for staff groups and service user groups? So I think part of that is how much do we go down the role of co-production in terms of policy, as well as individual plans. And then support for staff and service users, carers and witnesses. All of those, there's a little thing on here I can point at apparently. No? It did do, I can't do it. It's meant to point at that something. Okay, but the support for staff, support, people need it because of the effects on them, if it happens. But it's also true for service users as well. It's true for witnesses of things. We were talking about debriefing earlier today. Where is the debriefing and support for people who have been witnessing it? 'Cause it can be as much of a trauma as if you've been part of it yourself. Okay? So where is that? What does it happen? When I say support also, we also heard this morning about, sometimes we need to challenge, particularly staff, because sometimes they're getting it. They're doing things in a way that might exacerbate the situation. How do we do that in a way that doesn't blame people, but helps them develop as workers and helps the staff group develop as well? I think those are key issues for us to be thinking about to take this area forward in a positive way. Okay, so about positively dealing with it, about the causes and effects. I think the level of co-production is important. And if we look at the NHS England 5-year task force plan earlier this year, first time I've seen it mentioned, it talked about co-production with service users, carers. Fantastic. What do we make of that? Where does that go to? And how does that affect the issue we're talking about? Actually, I think that co-production is wonderful, but I do sometimes wonder if we still have some of the old things around Victorian era that some people are deserving to be part of things and some aren't deserving. Okay? And I think sometimes we're making decisions about who can be involved and who isn't on the basis of some sort of moral thing that might affect whether we think people deserve to be able to be involved or not. Okay, so patients' involvement in treatment is important. I think 360 degrees is important. So if something's going on, how do we take account of all these different perspectives to make sure that we're dealing with everything as we should be? I might mention this a bit later if I get time, but it's something we're doing in our area in East Anglia about use of safer systems analysis, human factors with our local mental health trust. The other part that comes from the guideline is the importance of external input in good governance. Okay, so key features of the guideline. Consequences of violence from mental health patients, this is the terms used in the guideline, on workers and clients and patients themselves and others in their formal and informal networks. We mentioned that. And it addresses how we might respond most positively to workers and patients, service users before, during and after these incidents. The updating of it was from a previous 2005 guideline, and the report talks about advances in taking account of service users' views, I could say it, service users' views on the use of physical intervention and seclusion, the effectiveness, acceptability and safety of drugs and their dosages for rapid tranquilisation, and all health and care services are involved, not just mental health. That includes primary care, community care, etc. Okay. The idea for a need for a guideline was there because violence and aggression are relatively common and have serious consequences in such settings. Just quickly, 60,000 physical assaults. This is just physical assaults, okay? Not all the other types that there might be, we'll look at that in a moment. But there's been a steady rate of increase in that in recent years. Of those 60,000, over 43,000 were in mental health or learning disability settings. Occurs most frequently in inpatient psychiatric units, and most acute hospital assaults take place in the emergency departments. That's Friday and Saturday night, I think, after people have been drinking. Maybe that's a bit of a, broad statement, but less well researched, as I mentioned earlier, in primary and community settings are these issues. But there have been deaths of 8 social workers since 1978 in community settings. And one of the biggest risk factors is isolation in a community setting. You're isolated from areas of support that there might be. The guideline talks about there being intrinsic and extrinsic factors, about the setting and context. We've heard quite a lot about that today, about what's the role of the individual who might be aggressive, but actually what is there in relation to the environment, the context, the staff group, maybe the member of staff that actually might have exacerbated that. Okay? The intrinsic factors, groups or as a combination of personality characteristics, current intense mental distress, and problems in dealing with anger. Extrinsic factors are more varied. Physical and social settings, the attitudes of those behaviours, violent or aggressive, the characteristics of the victims, and the experience of training of health and social work, social professionals, and the perceived risk of danger to others. Okay? That's just the areas that I mentioned those. So the definition the group used was a range of behaviours or actions that can result in harm, hurt or injury to another person, regardless of whether the violence or aggression is physically or verbally expressed. Physical harm is sustained or the intention is clear. So it's not about motive, it's about the effects and the actual what goes on. Very quickly, we know these things. The work of Holmes and others looked at this. Consequences can be far-reaching for staff. Most of the work's been on staff, interestingly, not on service users. But about absenteeism, injury, high staff turnover, lower quality of service, and decreased satisfaction at work, and costs to the agency, because of all that. Okay. There are effects on the patient and patient's network, partners, family members, or the wider patient service user group may be affected. Okay? The ripple effects of it, as I was saying earlier, can be extensive and could be long-standing. So you can think about an eco-map, so that you can look at how different bits of the system fit together and might affect each other and things like this. Staff may become wary and distrustful of perpetrators and or come to generalise their distrust and attitudes onto other patients and service users. So the attitudes we were talking about this morning of staff they stand back and become maybe more judgmental, okay, rather than the other way around, which is what we were hearing this morning was so important. So the labelling and othering, I'll move on this fairly quickly, but we did talk about that in the full guideline, about preconceptions, about people with mental health problems are violent, aren't they? No, they're not. In fact, they're probably less violent than other people, if you take the whole groups. Someone with a mental health problem is much more likely to be subject to violence than to offer violence. But the perception in the media and the public, and quite a lot of politicians, apart from Normal Land, but I missed him yesterday, but I can, it's a perception. And actually, it may be that the professionals involved have got those labelling elements as well. What does that mean for provision of a service? Okay, moving on from that. Okay, there can be effects on all sorts of things. We've mentioned about some of these things. Just mention that bit actually. I'm doing some work as a result of this with our local mental health trust in two areas. One, we're looking at developing policies about what happens after an incident, about a service user-led unit, which will look at what we're talking about. What's happened, why has it happened, whose account we take it to place, what do we do to change the services as the basis of that 360-degree look at those areas. Just looking at some stuff in Canada at the moment, actually, about staff who are subject to aggression and violence. They're starting to use peer supporters, which looks promising in terms of what people might be able to make use of. Key element of all this is about individualised experiences and effects on service users. What might affect you might not affect me, okay, in the same sort of ways. If I'm a service user, what's going on for me needs to be understood by someone else, and maybe, helpfully, for me as well. Where does that learning take place in a way that's positive and not actually labelling and othering of people's experiences? Okay. Risk assessments should be undertaken in collaboration. These are the italics of mine. They're from the guideline, but I'm just highlighting them. Risk assessments should take place in collaboration with service users known to be at risk and their carers, if possible. Those who work in these sectors, just thinking, are these things happening? Education, schools, health settings? Providers should consider training staff in methods of avoiding violence, including anticipation, prevention, de-escalation and breakaway techniques, depending on the frequency of violence and aggression in each setting. Big issue in community settings, there's no point teaching me how to do some of the techniques that are used in inpatient units. There's me, no one else. So really probably not very helpful. And that could be problematic, actually. But I'd be interested to hear people's views on that. Should train staff to undertake restrictive interventions and understand the risks involved in their use, including the side effect profiles of the medication recommended for rapid tranquilization, and to communicate these risks to service users. Okay, so non-pharmacological, seclusion and restraint, we talk about there, using restrictive interventions. The important bit I'll point out for our purposes, do not use restrictive interventions to punish, inflict pain, suffering or humiliation, or establish dominance. How do we know if that's happening or not? In terms of the motivations of some staff, maybe. How do we know whether that's part of it or not? Health and social care provider organisations give staff training, okay, to recognise the early signs of agitation, irritation, anger and aggression, understand the likely causes of aggression or violence, both generally and for each service user, techniques of distraction and calming. That kind of comes back to that bit earlier about advanced directives. What can there be that we can all learn together to reduce the risk for me if I'm a service user or a member of staff from those sorts of situations? Encourage relaxation. I'm not sure about this myself, encourage relaxation about that, but okay. To recognise the importance of personal space, yep. To respond to service users' anger in an appropriate, measured and reasonable way, and to avoid provocation. So I think you're kind of getting the idea, with a bit of luck, about what's been trying to put across. Physical restraint should be used as a last resort only, and other restrictive invasive interventions, including observation, seclusion, manual restraint, mechanical restraint, and rapid tranquilization, should always look for the least restrictive alternatives. If people get the chance, there's a wonderful exhibition down at the Wellcome Foundation in London by Euston Station on Bedlam. Okay? So to go along and have a look at that, if you have the chance, do it. I did manage to do it the other day, and it is rather sobering, shall we say. But actually, the ideas that some of the, like Tuke and Pinnell and the others were trying to do was fantastic, given the time that it was. But it didn't always end up as they hoped it would. So what's all that about then? Why do those wonderful intentions from those people not work out, particularly for Bedlam, which had to be redone completely at the end of the 18th century, because a government report said for all the work they were trying to do, whatever else you think about it, and going out on a Sunday afternoon to look at the people, you know, it's a family outing, wasn't it, for Victorian families? Unbelievable now, isn't it, really? But they did have some good intentions. That doesn't make it all right. But yeah, the government report said it had become cruel in the way that people were treated there. Okay, so the risks are to think about where might it happen, who might it happen with, when, why, and how. Isolation is a key risk factor in all of this. And people at risk, GPs, A&E, learning disabilities, health visitors actually, and CPNs. Real risk is where there's a coexistence of mental health and drug misuse co-occurrence. If there's any increased risk at all, it's in there. All the other things that were looked at in the guideline development group didn't show any consistent support for the idea that just because I've got a mental health problem in my head, I'm more likely to be violent. It's really important. Dementia, obviously. Key bit here, setting dysfunction. Okay, we can talk about some of that. And poor recording of risk assessments. The need to know previous behaviour in similar circumstances. Actually, and we're talking about service users here, but you know what? Some of that might be relevant to staff as well. So changing the focus from managing to prevention and de-escalation. There's a recognition it's not always possible to avoid violence, that's important. Grady set of interventions is needed to prevent minor violence from escalating to severe violence, we kind of know that. PRN isn't de-escalation. Some places think that's part of de-escalation, but it's not if that's the only thing that's being used. Okay? These highlights again, risk assessment procedures are there to increase the safety and well-being of all involved from each person's perspective. Okay? I'm getting boring now, aren't I? But I think it's so important when people are drawing those bits out, please. So it's actually about a projective understanding for each person involved. Not just the member of staff or members of staff, or for the service user, but for carers, for other people who might be part of that group situation, the ripple effects are really important for us to take into account for everyone's well-being involved. Okay, so positive engagement, that's a quote from the guideline again. To look at the root causes of problematic cultures. Okay, these things that I'm highlighting. Tim Kendall, who was part of this group, director of the National Collaborating Centre, we now want to see a culture of tolerance towards people with mental health problems, helping health and social care professionals to de-escalate difficult situations and help service users get the support when they need in the circumstances, sorry if I read that wrong, in the health service and can make things worse. Okay, you can read it, I said it wrong, so I won't read it again. We want to reduce the times when we restrict people who are wound up by mental health problems and placed in restricted environments. Develop a culture of learning from these things we've been talking about in relation to human rights and safety. And that would be a major step forward. Nearly done. Sorry, Merv, nearly done.
No, you've got 5 minutes.
Oh, blimey, ages. The important thing is ensuring effective service leadership. Peter Drucker, who is a management consultant, don't normally listen to him, but actually he's quite a useful one. He said, culture eats policy for breakfast, lunch and dinner every time. You can have policies till we're blue in the face. It's actually about how it's carried out in practice, about the impetus and commitment for people to take forward those values and ideas and practices. That's the key bit. Policies, only good if actually there's a leadership and the commitment in the organisation and the staff to carry it through. Okay, we should look at all this stuff and the outcomes in terms of outcome measures, safety, effectiveness and service user experience. Okay, you keep seeing that bit in there, which I think is really good. To always involve service users in the process. And this idea we're looking at with my local trust at the moment is how we look to, when there's been a restrictive intervention, having investigations. We're trying to move away from words like debriefing. We're not quite sure that's right. And actually, to have an inquiry. It's not an inquiry. It's to look at why something occurred with everyone involved. But final decisions about that are made by service users, and that goes to the board of the trust. Okay, does that make sense? I think that's really important, and we're trying to move forward on that at the moment as a result of some of this work. And the information from all that should be shared with the teams and services involved, shared with the trust board or other governing body, and linked to the standards set in safeguarding procedures as well. Individually, it's maybe help people, if I've been violent, to help me understand what my triggers were, could be part of the advanced directives again, and part of a care plan. Interesting. If that was recording the care plan, if I was a service user, would I get to see it? Would it be reviewed over time? They often sit there for ages, don't they? A year ago might not be right. I might be somewhere very different by that stage. In fact, the staff group might be very different in a different place by that stage. Key bit, and we've heard this quite a lot today, I think, communicate respect for and empathy with the service user at all stages. In this instance, it's about de-escalation, but it's just in general, isn't it? Okay, we've done that bit about involving everybody, evaluate over time to make any adjustments in care plans or environments. That's the key bit, or environments. Modifying services, record it, again, with patient service user involvement. Did you make that clear? But I think it should be. Okay, I'll whip through some of these things now. Okay, now I've got the slides if you like to, if you want to get them from me. So the service user monitoring unit, we talked about earlier, there's a few people worried about this. I know in my local trust, oh look, it says we've got to do it in less than 72 hours. Well no, you can't do this in less than 72 hours. What you can do is to start the process and make sure that something's happening. Otherwise people think, we've got to get it all done in 72 hours. Do it in 72 hours, that's not going to be what the aim was, I don't think, personally. It's a process, it's beginning the process to know it's happening, who's going to be involved, and how it's going to happen. Okay, with people who are trained to undertake that, and uses information from interviews with staff, service users and any witnesses, okay? To look at the effects, including witnesses, and what should be done about it. And that might feed back into staff education and training, obviously. Okay, just the last couple of things. really like it. I sometimes like to make use of, I don't know if people are familiar with this, it's Einstein's ladder of participation. Einstein, tomato, tomato. Einstein's son said it's Einstein, so I'll probably stick with that, okay? We don't have any debate about that. And it was actually in relation to citizen participation. Some people won't like one of the bits on the next slides, but I'll explain it in a moment. It's about information, consultation, deciding together, and the best thing is acting together, okay? So the idea is almost like a hierarchy. Information's good to have. Someone give me information, so what? Someone can consult with me, that's good. Have they done anything with it? Has anything changed for them? Deciding together is quite good too. But actually, acting together is the bit that really should be what we're aiming for. Just some research I did a few years ago with some colleagues. We looked at risk assessments in relation to plans, and particularly aggression and violence. Maybe we just couldn't find it. We couldn't find any evidence of service users or carers being involved in those risk assessments. This was a few years ago now. Maybe it's all moved on. But okay. Now, this is Einstein's ladder, okay? The idea is you can make it look as though you're doing something with service users, but actually just manipulating service users, okay? You have a big group, 30 people, but one service user. Is that consultation? No, I don't think so. This is one that really gets people going, therapy, okay? This was produced for about 40 years ago, all right? Maybe therapy was a different place then, but Einstein would have seen therapy, valuable that might be in some ways, is not part of co-production necessarily. It is now, hopefully, in some forms of therapy. But, okay, maybe we're going to move on from that. So inform people, that's all right-ish. You can consult with people. You can placate people by doing those things. The good bits is a way of measuring what we're doing about having partnership between service users, carers, professionals, agencies. Delegated power, which actually would be a little bit of, if there was a service user monitoring elements we were just talking about. And the top one is citizen control. People develop it themselves. And the professionals actually are there to help and support that. So it's just a way of thinking about hierarchies of co-production involvement. Won't get into too much, I've run out of time, but we're looking in our area about using the safer systems approach and human factors, which is kind of being used more in the health areas now. I'm interested in looking at that in more social care areas as well. In mental health trusts, about how we work with people from all different perspectives to look at potential risks in the future. What do we do? Because we know about it, people know about risks. Don't have to wait for it to happen. People know. How can we look at that and try and work on them before they happen? And I've talked about that one as well, that we're doing already. Right, so important is level of co-production. Have 36, 360 degrees perspectives on planning, reviewing what we do, being involved in critical incident analysis, everyone having an equal part in that, being part of records that are made. What if someone disagrees about a record? If I'm a service user, what if I disagree with what's been put on my record? Can we agree? Do I have my own bit? How does that get put through? Restorative justice, I'm a great fan of. Apart from where bullying takes place, there's a problem with that. But in the main, restorative justice can work really, really well to help people learn how to deal with difficulties in the future. Things like mediation. We thought about that. That can really help. And the bit about external input. It's not good to have units of people, physicalities, which don't have some external view of it in the main. And thank you very much.